Now, look at the eyes. When you are trying to have a conjugate gaze, the right eye is moving but left eye is unable to adduct. So there is an adductor lag. And whenever you are trying to look up, the right eye is unable to look up. When you ask the patient to look towards his nose, the convergence reaction is absent. So that is the reason it is a oculomotor nerve palsy, but not internuclear ophthalmoplegia. This we discussed so many times, doctor. How do you differentiate oculomotor palsy from internuclear ophthalmoplegia? At least 100 times in the same location standing I taught. It is all there in the UMedico app. Even recently we discussed it in our evening chai pe charcha sessions. But still once more I will tell you. Right? Once more. Midbrain, pons, medulla. Here you have third, fourth. Here you have fifth, sixth, seventh. So this is your right eye. This is your left eye. You are sitting in the reading room and trying to study. But a beautiful girl is passing on to your left side. Right? So then what you should tell? What your left eye is trying to do? Your left eye is trying to look at this curvaceous beauty in the reading room. Right? Then what should right eye should do? It can't keep looking straight while this is looking left, right? So it has to undergo adduction while your left eye is undergoing abduction while you are having a left gaze. Then how will the right eye oculomotor nerve knows that the left eye is undergoing abduction? For the left eye's abduction, what is required? Sixth. So the sixth nerve nucleus has a communication to the third nerve nucleus of the right eye. So when the sixth is undergoing abduction, it informed the third nucleus on the right side that, hey boss, I am abducting, there is a beautiful girl passing. You also adduct, it will tell. But suppose if this medial longitudinal fasciculus is abnormal, demyelinated in condition like multiple sclerosis, then the third will not know on the right side that the left sixth is abducting. So that is the reason this adductor, this eye will not be able to adduct. It won't adduct. So that is called adductor lag. The side where the adductor is lagging is called as the side of medial longitudinal fasciculus and internuclear ophthalmoplegia. So if the right eye is not adducting but the left eye is abducting, what will happen? There is a diplopia, and because of that, immediately this abducting eye, arre beauty ko chhod do, mera to do dikh raha hai, ek bhagyalakshmi gajalakshmi dono dikh rahe hai. So isliye immediately it will come into nystagmus. So that is typically the nature of one adductor lag, and the abducting eye coming back into nystagmus constitutes the internuclear ophthalmoplegia. Now you may ask a question. Suppose if the problem is not MLF, but the problem is directly with the nucleus, oculomotor palsy is there, then also this eye cannot adduct, no? So how do you know that it is MLF or whether it is the oculomotor palsy? There should be a way to know. So you ask the patient to look close towards his nose. When you look close to your nose, what happens? Your both eyes adduct, right? For that, do you require MLF? You don't need. So suppose if the MLF lesion is there, then when you try to do the convergence reaction, eye still adduct, right? But if it is a lesion in the oculomotor, then if you are having lateral gaze, then also adduction lag is there. When you try to do the convergence also, the eye is not able to adduct. Both the situations, if the eye adduction is not happening, nahi ho raha hai, then culprit is oculomotor nerve nucleus. But only during lateral gaze only adduction is not happening. That means it is MLF lesion and internuclear ophthalmoplegia, where convergence reaction is normal, is what you need to remember. So one of the pictures that has been shown to you, when the person is trying to look towards his nose and trying to converge, there is no, there is still the adductor, lag in adduction is there. So this side, the adduction lag is still there. That's how you are able to differentiate. Another thing is, there is also a ptosis. Ptosis is not a feature of internuclear ophthalmoplegia. That's another way to recognize. Now, doctor, normally lumbar spine may, is there any abnormal curvature, is a very important question. Yes, lordosis. Anterior bowing is called lordosis. Lord Mountbatten, aisa chalta na. So anterior curvature is lordosis. Then backward curvature is kyphosis. Normally lordosis will be there, but if it is missing, then how the person will be? He will be like swaying back and walking, right? Then normally thoracic kyphosis is expected, but if it is missing, then first your neck will walk, then you will walk, right? Otherwise, this is a good posture. As such, you are in NCC or the department, police department, right? So, normal spine versus lordosis of the spine and exaggerated lumbar curve. अभी आ गया हमारा favorite question. Every day evening in the चाय पे चर्चा, हम रोज cerebellum के बारे में बहुत बार चर्चा किए. I told you November exam 2018, while attending the exam, you will remember Dr. Murali Bharadwaj, because without cerebellum there is no physiology at all. You should know everything, anything about the paper. So inferior olivary nucleus कहाँ रहता? Medulla में रहता. That is the one which will be reaching towards the, sending the all afferent information to the cerebellum. And in the cerebellum, how is cerebellum connected with the brainstem? The medulla is connected with inferior cerebellar peduncle, pons with middle cerebellar peduncle, and midbrain with superior cerebellar peduncle. So what is the purpose of the inferior cerebellar peduncle? It will bring all the information to the cerebellum, middle also. Superior cerebellar peduncle takes the information out of the cerebellum and goes to the midbrain red nucleus, from there to the thalamus, from there to the sensory cortex. So that is called as cerebello, that is dentate nucleus in cerebellum, right? So dentato, rubro, that is red nucleus. Thalamo, cortical pathway, right? From sensory cortex, once more what will happen? Information will go to the motor cortex and once more it will descend down. So that is what you need to basically remember. So inferior olive is typically located in medulla. It is, what does it do? It brings all the sensory information. So how does inferior olivary know all that information is a very important question. Medulla is well connected with what? the spinal cord. All spinal cord, dorsal column, spinothalamic tract bringing pain and touch, pain and temperature, they all reach the medulla. There they will tell in the ears of the inferior olive that, hey, this fellow is walking, doing skating, abhi Himalayas ko aa gaya ye, unke pav ke niche snow hai. That it will tell to inferior cerebellum, inferior olivary nucleus in medulla. From there, inferior olivary nucleus will tell ole ole to cerebellum through inferior cerebellar peduncle. Then from the cerebellum, Purkinje cells will say ole ole to the thalamus, and from thalamus sensory cortex. Meanwhile, thalamus will say, hey cerebellum, thank you for the information that you are passing to me, but at the same time I also got an information from all the lemniscus, medial lemniscus, everybody also came to me and told the same information. So there the thalamus will do matching. Cerebellum से जो बोल रहा है और हमारा regular sensory input आ रहा है, दोनों एक ही है ना? Ah, very good. Then it will tell to the big boss, sensory cortex. So beautiful is the creation of the God, is what you need to remember. So the inferior olivary nucleus typically will pass to the inferior cerebellar peduncle and informs it, and the cerebellum in turn will send through the superior cerebellar peduncle information to the red nucleus and the ventrolateral nucleus in the thalamus. From the thalamus, it will go to the sensory cortex, is what you have to fundamentally remember. Where is the location of Meissner's corpuscles? Very good to see around 260 online students. So how many of you are first timers? Please punch. Please give a call to our WhatsApp number, and you get a subscription to the video library on the UMedico app, and only if you subscribe we can pay to our faculty. I am free, but other faculty we have to still pay. So if you subscribe, it will help us to pay the bills. So please do subscribe. It is a very cheap subscription for 5,000 bucks. You get a 2 months of subscription. Yes. So Sridevi, Nand Kumar and many more, please also tell your friends to come for every day, all 365 days. We will have a 3-hour session. 1,000 hours we give you free. Interactive session, because we are also jobless, unemployed. We have no other work and we can't do any other work as happily as this, to spend time with you guys. So where is the location of Meissner's? Meissner's is located in papillary dermis. So typically in the papillary layer, it is a loosely woven area, and the Meissner's corpuscles detect the touch and the free nerve endings detect the pain, is what you have to ultimately remember. So this is how histologically the Meissner's corpuscles typically look like, is what you need to remember. Now what is this layer which is marked in the retina, which you are able to see? So you should remember that you have visual information falling on photoreceptors, rods and cones. That goes to the horizontal cells, bipolar cells, emacrine cells, ganglion cells, and finally it will produce the spikes. So the bipolar, emacrine, ganglion constitute inner plexiform, whereas the photoreceptors, horizontal and bipolar cells constitute the outer plexiform layer. So you have a pigment epithelium, the photoreceptors, the outer nuclear layer, outer plexiform, inner nuclear, inner plexiform, ganglion cell layer. So that is how the various layers of the retina, one of the favorite question of the layers of retina. Where is the Golgi apparatus in SNR cells? Suddenly, if this kind of question comes now, don't cry in the exam hall, right? Or don't get tempted to put some answer, even if you don't know. First of all, what is SNR, serous SNR cell, how it looks like, without knowing also. अंग्रेजी आ गए तो कुछ ना कुछ लगाने का, आंसर लगाने का, the mind is a horse, right? It has so many disgusting fantasies, right? So we attempt to answer and 1/4 mark out. Remember that out of the 300 questions in NEET PG, 260 spinal cord level से answer कर सकते, coda equina can answer. Only 40 questions you require, some thinking, knowledge. I mean, some they are all surprises or they are stupid questions you can't answer. Even you are a Maharshi also. So this is one such question in my opinion, though it looks very benign, right? It is supranuclear. If you look at the serous acinus, the basal portion of the cytoplasm has got a lot of rough endoplasmic reticulum because serous acini produce a lot of protein in their secretions. So a typical acinus unit, if you look at it, it has got a small lumen, round nuclei, well-stained cytoplasm. It has got a apical cytoplasm and apical area you have secretory vesicles. And the Golgi apparatus is typically located in the supranuclear position is what you have to ultimately remember. Now doc, patient with syphilis is unable to walk with the closed eyes. He has got a stomping gait. What is the tract involved? I think easiest question in the planet. Dorsal columns will bring your vibration sense, touch sense from the lower limbs. You are able to be in a good balance. How are you able to do that? Eyes and feet, right? So, suppose if your cerebellum has some hemorrhage, it's a balancing area in the brain. What will happen? What will happen? Romberg's test will be positive. That is, you will be imbalancing because brain is the area where balance is maintained. But there, why cerebellar dysfunction lead to imbalance? Typically, the information you are getting from the vestibular nucleus, from the vision, from the dorsal column. All the three will be reporting to the, who is the reporting authority? Cerebellum. After getting the information, what you are seeing, what you are listening, what your vestibulocochlear nucleus is telling and what your dorsal columns are bringing through the inferior olivary nucleus to the brain will bring the balance. Whereas, if you have vitamin B12 deficiency, subacute combined degeneration of spinal cord it is called, your dorsal columns are demyelinated. So, you are not getting out of the three information to the brain, cerebellum, two only are working. What are they? Vision and ears. Ears contribute very little, but vision mainly. So, when your dorsal columns are dysfunctional, though the cerebellum is not getting the vibration perception of the feet, still your eyes know how is the surface of the ground. They are seeing. That's the reason you don't have any imbalance when your eyes are opening and you are walking. If you have a dorsal column degeneration, that is subacute combined degeneration of spinal cord. But you come to a wash basin to rinse your face, you close the eyes and then rinse your face, you will fall down. Because your eyes closed and your dorsal columns have vitamin B12 deficiency associated degenerative changes. So your cerebellum is handicapped with the both visual and also the sensory information which is coming to dorsal columns. So the moment you close eyes and then rinse your face, you will fall down. Now what is that called? Wash basin phenomena is the name given for the imbalance which is caused when the person closes the eyes but not when his eyes are open. This typically happens when his dorsal columns are degenerated, though his cerebellum is normal. Whereas if the cerebellum itself is abnormal, whether you open the eyes or close the eyes, still you will have imbalance. So that is a typical way you differentiate. So what happens in syphilis? Tertiary syphilis you will get tabes dorsalis. Just like vitamin B12 deficiency lead to the dorsal column degeneration, even syphilis will lead to vasculitis, small vessels supplying the spinal cord become stenotic, and blood supply to the dorsal columns is affected, and that lead to development of the dorsal column dysfunction is what you have to basically remember. Ligamentum flavum consists of what? Once more, a favorite standard question of the examiner. एक टाइप ऑफ कोलेजन के बिना कभी क्वेश्चन पेपर होता क्या? नहीं होता, नहीं होता. Type 1 is there in bone. Type 1 collagen, right? Type 2, where do you have? Cartilage के अंदर type 2 collagen is there. Basement membrane में what do you have? Type 4. So if you look at the ligamentum flavum, it has got elastin is what you have to basically remember. So elastin has got the mechanical properties, and it is present less in tendons but more in ligaments. So it is there in ligamentum flavum is what you need to remember. So this is the typical way by which the ligamentum flavum is the one which you can see in the vertebrae is what you should appreciate. Whereas reticulin was one of the options. It has got type 3 collagen. Reticulin is that scleroprotein in the connective tissue fibers, and you use a agyrophilic stain. It will be typically become black if you do the silver impregnation technique. If you look at the recent AIIMS question papers, one of the question was on where do you use the agyrophilic stain, which is silver impregnation technique, to discover the reticulin bolke question was asked. So examiner is a very interesting guy. He has got very standard topics in question bank. So too much reading is too bad. 650 topics are there for examiner, 20,000 points, 5,000 muggable, you can't help, 15,000 guessable and learnable. They are the things which logically you should understand. 5,000 muggable. So the muggable, learnable points of the 20,000 bullets. If you are ready, you are bulletproof NEET PG aspirant. That's my whole purpose to be with you. Left superior intercostal veins, where do they drain into, is a very, very interesting question. Once more, doctor, the venous drainage of the intercostal space is one of the favorite area for the examiner. Right or left का अलग story होता है. There is a different story. Right supreme intercostal vein drains the first intercostal space on the right side directly into the right brachiocephalic vein, sometimes into vertebral vein. Left supreme intercostal vein drains the first space and it also goes into left brachiocephalic. Then second and third spaces, they go to left superior intercostal vein and ultimately to the brachiocephalic. Whereas the fourth, fifth, sixth intercostal spaces on the left side, they typically go into the hemiazygous and accessory hemiazygous vein they drain into. Typically on the left side you have the hemiazygous and accessory hemiazygous. Whereas on the right side, second and third goes into the azygous. Directly the azygous will form an arch. Azygous will form an arch before it drains, right? So they go into the arch via right superior intercostal vein. Then fourth, fifth, sixth, all will go into the azygous on the right directly. So on the right side mein azygous hai, left side mein hemiazygous hai, but first ones always go into brachiocephalic. That is what examiner is specifically asking. Many times he asked, so there is nothing new about it. Which are all cranial nerves associated with olfaction. I doubt whether he asked olfaction or with the chemical senses. Basically, in the oral cavity you have gustation. Then In the nasal cavity, you have olfaction. So examiner asked olfaction, I doubt it. He might have asked about the chemical senses. That's right. For the gustation, you require facials, chorda tympani anterior 2/3 and glossopharyngeal posterior 1/3 for the taste. And for the chemisthesis, oral cavity, trigeminal. Then in the nasal cavity, olfaction is the olfactory is what you need to ultimately remember, right? So for today, 25 questions. Kal aur ek 25 release karenge, provided you promise me you will bring another 200 of your classmates.